Okay, so we'll go ahead and start with the respiratory or chest radiology. This is following the USMLE content list. And we're going to start off with a quiz, which is different from the quiz you have, and then review normal structures, head and neck, infection, neoplasm, various lung diseases, pneumoconiosis, pulmonary emboli, pleura. There's going to be limited coverage of pleural disease and respiratory failure, and no coverage of trauma and congenital disorder. Just can't fit it into one lecture. So we have like 15 quizzes. So the right lung has how many lobes? 3, okay. The trachea bifurcates at what level? Any guesses? C4, okay. I think we have 8 people logged in addition to me, so hopefully we can hear from everyone. C8, C4, T4. Okay, we will find out. What is the most common cause of sinusitis? Most common cause of sinusitis. This is an open-ended question. Allergy, okay, that's a good guess. Any other thoughts? Infection, okay. What kind of infection? Viral, okay, good. Life-threatening hemorrhages from nosebleeds involve what vessel? Internal carotid artery, sphenopalatine artery, superficial temporal, middle meningeal. Life-threatening hemorrhages from nosebleeds, epistaxis involve which vessel? Any guesses? We think sphenopalatine, okay. What is the most common type of head and neck cancer? Adenosquamous small cell transitional cell. Any guesses as for the subtype of head and neck cancer that's most common? Usually related to smoking, alcohol exposure, sometimes viral, EBV, especially in immunocompromised squamous. Patients with obstructive lung disease have high flow, normal flow, or low flow, lung flow volume. Obstructive lung disease versus restrictive. So those are the 2 types that we're going to review. So we think low flow. Okay. A 65-year-old man with lung disease has a pinkish hue, thin, barrel-chested, with cachectic appearance. What is his probable underlying lung disease? Bronchitis, emphysema, interstitial lung disease, pneumonia. Okay, so the agreement is emphysema. This type of condition is due to mixed type 3, type 4 hypersensitivity reaction to environmental antigens. Presents with cough, dyspnea, chest tightness, headaches, often seen in farmers and those exposed to birds. Which type? Any guess? C, interstitial lung disease. Okay, is that what everyone thinks? A, silicosis. Okay. Any other guesses? I take it the rest. Any other? Okay, so we're between A and C. Okay, silicosis and interstitial lung disease. Chronic bronchitis is due to what process? Alveolar lung destruction, glandular hyperplasia of the bronchi, ciliary dysfunction, malignant transformation. What is the underlying cause of bronchitis, chronic bronchitis? Pathophysiology. A, alveolar destruction. Okay. So it sounds like maybe that's D or C. Ciliary dysfunction versus malignant transformation. Okay. All right. I love you guys are such an awesome class. Love the interaction. Okay. A person has rheumatoid arthritis and pneumoconiosis with intrapulmonary nodules. What is this syndrome? Cardiac anger, Kaplan, cystic fibrosis, Down syndrome. Rheumatoid arthritis, pneumoconiosis, and pulmonary nodules. Any guesses? A, cardiac anger. Okay. Any other guesses? Everyone thinks it's A? Never heard it, or A or B. Okay. Cardiac anger or Kaplan. This one's coming out of first aid. Silica and coal affect which part of the lung? Upper, lower, or there's no preference. Silica and coal affect which parts? Upper, lower, or no preference? B. Lower, okay. Maybe it's heavy, so it comes down. Okay, that's reasonable. Anyone else? Or are we all thinking it's probably B? Okay. Asbestosis affect which lobes? Upper, lower, or no preference? Asbestosis affects which lobe? This one's also coming out of first aid. Upper, okay. Half of the patients with eosinophilic pneumonia have what underlying condition? Asthma, asbestosis exposure, smoking history, lung cancer. Okay, good. True or false? In the lung, metastases are more common than primary cancers. True or false? False, true, true, false. Okay. You guys are awesome. Okay, so let's go and get started with normal structures, functions. These little subtitles are copied and pasted directly from USMLE content list, and we're going to follow those little subtitles just so that we're covering all the materials that you are expected to at least have heard once. So this is coming from first aid. The trachea and the bronchi have cartilage surrounding it, so it maintains the caliper. And then the smaller bronchioles, terminal bronchioles, don't have cartilage that keeps it open. So these are mostly just ciliated cells and smooth muscles. And you can see this on CT. This is a CT of the chest coronal view. These little hybrid density rings around the trachea and the bronchi are the cartilage. And then as you go more peripherally, there's no longer cartilaginous surrounding the airways, just muscle. Okay, so that's the main airways. The right lobe has 3 lobes, upper, middle, and lower, and the left has 2. The middle, we'll see some chest radiographs, but the heart is bound on the right heart border is bounded by the right middle lobe. So if there's consolidation, then you'll lose the right heart border, and we'll see an example of that. And you have how many fissures on the right? So the right has how many fissures, and the left has how many? Good. So the right has the minor or major fissures, and the left has 1. That separates the upper from the lower. The right, if people aspirate food, it usually sort of comes down the right because it's more vertical. Left, but it can go to either side, and it usually goes in the dependent portions. The pulmonary artery, the right side is anterior, and then the left is superior. The left goes over the left main bronchus, and we can see that on the frontal radiographs. So these are examples of frontal and lateral radiographs, frontal and then lateral. So you can see the fissures. So the fissures, in normal patients, you don't see them because they're not visible by radiograph. You can see them by CT. But if they're pathologic, for example, if the patient has pleural effusion from CHF, then you can see the fissures being outlined. But typically this is sort of where the boundaries are. The right upper lobe is divided by what fissure? From the middle lobe. Minor fissure. So the right upper and the right minor, and the minor fissure separates the middle from the upper, and then the major fissure separates the upper from the lower. Okay, and then the left, we really just have the oblique fissure, which is here. So, posteriorly, the lungs go much more inferiorly here, as you can see, compared to the anterior, right? So on the frontal, even though we see the diaphragm here, there's still tons of lungs that we're not really seeing well on the frontal, but we can see very well in the lateral. So when you all start internship and residency, you really want to get 2 views. If patients can get 2 views, We have the saying in radiology, one view is no view. You really need two views to have diagnostic confidence and also to co-localize disease processes. That's important. And then here you can see on the lateral, this is the spine. So as you go down, it gets more lucent, right? It gets darker. And that's normal. So if you lose that normal lucency as you go down south, then that means there's a pathologic process, like a pneumonia or a mass. And the reason it gets more lucent as you go down south is because as you go down south, there's more lungs. And so the photons pass through the lungs, and so you get attenuation. The diaphragmatic structures, this is from the first aid. So you have the sort of a tendinous part and the muscular part. And then you have three hiatuses for the IVC, the esophageal hiatus, and then the aorta. The aorta is the most posterior one. You can have congenital defects within the diaphragm, and if you do, then it's basically a defect, and so abdominal contents can then herniate up into the chest. So what do you see here on this frontal chest radiograph? Is that normal? Abnormal? Intestines, good, yes. So we see gas, bowel gas up in the left chest wall. And what else do you see? Where's the heart? The heart normally lives on the left side, and here the heart is being displaced contralaterally to the right side because of the herniation of small intestines from a congenital diaphragmatic defect. So this can happen congenitally. It can happen by a lot of different causes, like trauma. People who get stabbed, for example, they can get herniation of abdominal contents into the chest, varying degree. The heart looks big. It maybe, it's hard to say, but it does look a little prominent. This is the ET tube, the endotracheal tube, and you see that ET tube is also being displaced because of mass effect from the diaphragmatic hernia. Is this a child? Very good, very perceptive. Yes. And why do you know that? So children have physes, thymus. I think a more reliable marker is to look at the bones. Children have physes, and so it's lucent. So you see here, you don't see it because it's just cartilage. It still has to develop. So that's why you know as a child. Good. Budding radiologist. Okay, number of letters. Is the herniation gravity dependent? The question is the herniation gravity dependent, or is it the intestines are trying to move to an area of less pressure? I don't think it's gravity. I think it has more to do with maybe the pressure. The chest, typically, there's like that negative pressure effect. So if there's a defect, then, there's the belly, the contents will go wherever there's low resistance. So the levels, the aortic hiatus is the most inferior and posterior at T12, and the IVC comes out at T8 and T12. This is from first aid. And then the C3, 4, 5 are the nerves that innervate the diaphragm. So if you have problems with the phrenic nerve, then you can get paralysis. Other bifurcations, common carotid bifurcates at C4, trachea bifurcates at T4, and then abdominal aorta bifurcates at L4. Okay. So the trachea bifurcates at T4. Organ structures and function. So review of the pleura, nasopharynx, and sinuses. So we have the nasopharynx, so the head and neck part. We have several sinuses. This is probably the larger one. It's the maxillary sinus. And what are some of the other sinuses called? Frontal, good. What else? Ethmoid, good. And the final one is posteriorly, up a little bit higher, below the pituitary. It's sphenoid. Okay, good. And then we also have, good, we have mastoid air cells, and then there's the eustachian tube, and this is the nasopharynx here. This is a fossa of Rosenmuller. If you have a mass lesion here, it'll obstruct the eustachian tube, and then it'll cause obstruction, and then you get opacification of the mastoid air cells fluid. So if you see the mastoid air cells being opacified, you have to look at the nasopharynx to look for an obstructing lesion, because that's one cause of mastoiditis. Good. Okay, so this is a frontal radiograph. Which cells? So this is the mastoid air cells. So what I was saying is the eustachian tube communicates the nasopharynx to the inner ear. So if you have obstruction of the eustachian tube from a mass, like a squamous cell carcinoma or a metastatic lymph node from an SCC, then it can cause obstruction. And you might not see that directly, but you'll see the mastoid air cells opacified with fluid from obstruction. So if you see opacified mastoid air cells, check the fossa of Rosenmuller to look for underlying lesion. So this is the frontal radiograph of the chest, and I'm trying to outline the pleura here. So what is abnormal about this image if you see an abnormality? Or is it normal? Pneumothorax. Okay, so where do you see the pneumothorax? Right, left. Good. Okay, so this is the normal lung. You see the lung tracings all the way to the edge of the lung interface, and that's where the pleura ends. And here on this side, you don't see the lung markings extending to the edge of the lung. Instead, you see this lucency, and then you see this pleural reflection here. And this is from a pneumothorax. And yes, astutely, Peter pointed out that the heart is also being displaced to the right. And what does that suggest to you, Peter, when you see the heart being displaced contralaterally? Is it a simple pneumothorax? Tension pneumothorax, good. So tension pneumothorax, the problem with that is it's a ball valve mechanism. Air is coming in, but it can't go out. So then it causes mass effect on the heart, and so you get poor heart return, so then patients can get cardiac compromise pretty fast. Why is the exposure so bright? So this is a portable, so there's two ways to capture a radiograph. One is portable, where the technologist takes the x-ray machine to the patient's bedside and take the image. The second way is to have the patient come to the radiology department and do a frontal and lateral radiograph. So this is portable, and you know it's portable because the quality is sort of iffy, which was what Andrea raised about it being a little bit overexposed. Because the detector and the source of radiation, they're not optimized, and so you can get over and under exposure, and then sometimes this is not bad because sometimes you can have all these wires and tubes over the patient, and that makes it really even harder to read. Does the upright mean the patient is standing though? Yes. Oh my gosh, you guys have so many good questions. Yeah, so there are different ways to capture radiograph upright, so they could be sitting up on their chair. That's usually that's how they do the upright in patients who have a portable radiograph. So they'll sit up and then they'll do an upright versus in the radiology department where they usually stand. And it says here AP, anterior, posterior. That's another indication that it's a portable. So with portable, the radiation, if you imagine the radiation source being a flashlight, the flashlight is coming from the front, and so it goes through the anterior chest and then into the posterior chest. And then if you had a flashlight that was projecting to the garage door, for example, the flashlight is the radiation source, and then it goes to the garage door, which is a detector where you see the images being then generated. So that's what AP means. So the source is going from anterior to posterior. In contrast to images done in the radiology suite, which is PA, posterior anterior. So the patient is turned around. So like if I was standing in front of the garage door, I would be facing the headlights of the car. At the radiology department, it's the reverse. I would be facing the garage door. So Kathy has a question. Are there infiltrates? Where? Here in the left lung? Like over here, you mean? Yes. So great observation. Oh my gosh, I swear your class is like full of like, if you guys all go into radiology, you would do superbly. So this is called bronchovascular crowding. When the lung collapse, as we see in this case, all the structures squish together, and so it makes this appearance of crowding, which looks like infiltrate, and it would be very hard to exclude infiltrate, but given the patient's clinical context, let's say the patient had trauma, then it's less likely to be infiltrate and more likely to be just bronchovascular crowding because you have loss of airway. Good. Next. Okay, so more sinuses. So we said this is the maxillary sinus. So up here, up high is the ethmoid sinus, and this is what part? That communicates into the intracerebral region. This bone is called where the olfactory neurons are. That's perforated. Good. Cerebroform plate, right? This is probably why when you eat wasabi, it goes like straight up into your sinuses and up. So good. So that's the ethmoid sinuses. Maxillary sinuses drain. So there's from the osteomeatal unit, which is right here, and it drains through the middle meatus right here. Okay, superior, inferior, and middle. So these are the ethmoid sinuses, and then this is a frontal sinus here. This is the septum, and then the nasal bone. Good. So now we're going to go up cranial a little bit so that we're imaging which sinus here. What sinus is this? Posterior is the maxillary sinuses. Adjacent to that internal carotid artery and in the sphenoid wing. Sphenoid sinus, good. Okay, so the patient here has normal or abnormal appearing sinus. What do you think? Abnormal, and what's abnormal about it? So sinuses normally are aerated, and in this case, it looks congested, right? There's thickening. There's a fluid level here. And then there's bubbles here, these little small bubbles. So these are signs of acute sinusitis. This is sinusitis. And there's two different types of sinusitis: acute and chronic. Acute sinusitis, you see fluid levels, bubbles, frothy bubbles. In contrast, chronic sinusitis, patients start to have bony changes. So here, if you look at the normal bone, it's more well marginated, well delineated. Here, look at the bones, it looks a little irregular, and the density is a little bit more sclerotic compared to normal bone. So we call this neoosteogenesis. So the bone starts to react from chronic inflammation and sinusitis. And also in chronic sinusitis, you see the maxillary sinus, it starts to look smaller than the normal maxillary sinus. So it pulls in, so you lose you get small sinuses basically. Peter had a question. Asymmetric, even distribution 2 in chronic. Asymmetric distribution. So I think the question Peter was asking is, do you also get asymmetric distribution of mucosal thickening in chronic? It's not so much the symmetry, it's just more of the underlying bony changes. You can have, for example, here we see pretty symmetric Oh, hold on. Sorry, those were two separate comments. Okay, all right, I was correct. Oh, got it. Okay, all right, never mind. So I will continue unless anyone else has any other questions. Bone. Okay, so Kathy had a question. The question is, so due to chronic inflammation by bone is reshaped, the bone reacts. So it's you get new bone formation. You see this little irregular bone. So it starts to react to the chronic inflammation. Reshaping, I mean, it you sort of lose a normal air, the cavity, the space, so it does get a little smaller. So I guess, but we don't really think about reshaping. It's more of the changes that happen into the bone, which is we get neoosteogenesis and like sclerotic changes with chronic versus acute, where we don't see the underlying bony changes because it takes time for the bony changes to happen. The arrow is pointing to which sinus? Any thoughts? Ethmoid. Ethmoid is posterior. This is very frontal. Good. So as you can see, these sinuses are in very close proximity to the intracerebral part, intracranial part content, right? So, and that's the problem with untreated sinusitis. If you had, say, for example, frontal sinusitis, a bacterial, you can easily eat into the bones and then extend into the and cause empyemas like extraaxial abscesses and maybe even extend into the intraaxial space. So that's why sinusitis are sort of important, because they're in a very sensitive area, and you can get rapid deterioration if not treated correctly and urgently and appropriate in certain contexts. Although most sinusitis is due to viral, so it'll usually just go away. But in some cases, for example, if patients are immunocompromised, if they develop sinusitis, immunocompromised patients, you think about them very differently from everyone else because they are predisposed to different kinds of unique infection. So they get mucor, for example, and mucor is a very aggressive fungal infection. And so if you have to recognize these, have this on top of your head of your mind, on your radar, because untreated mucor, for example, can rapidly advance and patients can die within days. So you get sinusitis when you have obstruction of the drainages and from inflammation, and so you get pain over the affected area, typically the maxillary sinuses, which drain into the middle meatus. So it's most commonly due to viral, and that's why we don't recommend patients get antibiotics because it's not going to respond, number one, and number two, it'll create antibiotic resistance. So patients with acute sinusitis are typically treated asymptomatic or conservatively, although you can develop superimposed bacterial infection. So patients will be more sick. They'll have purulent drainage. They'll start to develop fevers. And if that happens, it's usually from strep pneumoniae, Haemophilus influenza, and M. catarrhalis. So that's correct. Viral is the most common cause of sinusitis. So epistaxis. What would you give for sinusitis? Nothing. Patients just rest, recover. They can get mucor mist to try to clear up the sinuses, ocean spray, and then they get humidifier. So Andrea said, my lace doctor has given something, but I forgot. Sometimes they get this salt spray, which helps clear the salt, I guess, sort of clears the mucus and sort of the inflammation. So epistaxis. Okay, so epistaxis is nosebleeds. So most nosebleeds are typically sort of just from the capillaries, from the castle plexus, and those are usually like anterior. But you can get life-threatening hemorrhages if you get if it involves the posterior aspect of the nasal cavity. So here, the sphenopalatine foramen has a sphenopalatine artery. So if this starts to bleed, then you can imagine how patients can sort of be gushing blood because it's a high pressure arterial system. So this, what is this sinus called again? Beneath some anatomy. Sphenoid, okay. And then this one is what sinus? Here, anteriorly. Good. And then this is, what space is this? Mastoid air, so that's good. Bilaterally, right? And then what courses through here? This one's the internal carotid artery on either side. Okay. So here you have the foramen rotundum. So patients who get sinusitis, for example, here, they, especially for example, aggressive fungal mucormycosis, you see like it can go into the arteries and then can very quickly advance into the brain. So it's incredibly important to identify aggressive sinusitis early because they advance very, very rapidly. And so patients can deteriorate very fast. So yes, life-threatening hemorrhages from nosebleeds involve the sphenopalatine artery. Okay, so more head and neck stuff. Again, I copied and pasted this from the USMLE content list, and we're just going to go down that list. So this is a lateral radiograph of the neck. So what is the structure anteriorly to the esophagus? Trachea, good. And what is the structure here? Posterior to the hyoid bone, good, epiglottis. And what is this space here called? This is the oral pharynx up here, and then here is the what? Nasopharynx, good. And then we look at the spine, and then we look at the prevertebral soft tissues. And here, you sort of like partially visualize the mastoid hair cells. Okay, so what's going on here? Is that normal? Abnormal. Epiglottitis, good. And what's the problem with epiglottitis? So you see this is the epiglottis, which is what it normally looks like, and here is very thick-walled and thickened. It can, obstruct the airway, right? So you can imagine, here's the airway going anteriorly and down into the trachea. And if it gets thickened enough, it'll just obstruct it, and then patients can get airway compromise. Good. In contrast, what do we see here? So we said this is the trachea, right, larynx, and so it's a nice wide caliber airway. And here, what do we see in these two images? Normal looking larynx, abnormal, atresia, steeple sign, okay. So what does that mean? I think both are pointing out the fact that that air is narrowed, right? It's narrowed, and here it's thickened, and so it's basically creating a very small caliber airway. And this is CRU. This is what CRU is. It's laryngotracheobronchitis, and Kathy astutely pointed out the steeple sign. So the steeple is this part, and that's what they're saying. It looks like a steeple. Not sure if I'm familiar with BOOP. Can you be more descriptive? Like bronchiolitis obliterans? Is that what you're talking about? Bronchiolitis obliterans is it's actually involving the airways in the lungs. Not so much the upper airways, which is what we're sort of discussing here. Did you have a specific question that you wanted me to elaborate on here? Pathogens causing CRU or bronchiolitis obliterans? BOOP. Okay. So bronchiolitis obliterans is, we'll get to the lungs. I'm not sure that we're going to cover bronchiolitis obliterans, but bronchiolitis obliterans is a fibrotic process. And so patients with, for example, post-lung transplant, they can get rejection, and then that causes the bronchioles, the little airways, to get stiff. Normally, it's got muscles and whatnot, so it's kind of elastic. But with bronchiolitis obliterans, it gets really stiff, so they have air trapping. Oh, that's okay. So did not mean to distract you. Just saw it on the slide and was not familiar with it. What? Oh, I see. Got it. Okay, sorry. Yeah. So we are up here, but hopefully we will make it down. And we'll talk about organizing pneumonia in the subsequent slides. So we'll get to that. Infectious disorder. So we're making our way down. So we did the epiglottitis, croup, and now we're going to talk about pneumonia, bronchiolitis, and then aspiration. Okay. So this is a normal chest radiograph. The patient. This is probably a PA, like a posterior anterior, because the heart is small. A PA, as we said before, like if you have the headlights, which is the radiation source, then in the PA, the patient, or I would be facing the garage door. So the heart is closer to the garage door, so it's going to be smaller. In contrast to AP, which is typically done portable, you're facing the car, the headlights, so then the heart will be bigger because it'll project into the garage door. So that's what's normal. And what's abnormal here on this image? Or is it normal too? What do you think? Okay, so Andrea thinks it's abnormal. It's cloudy. Where? Right, left, up, down. So there's an infiltrate in the right middle lobe. Good. And why do you say it's right middle and not right upper or right lower? So it's touching the right heart border. So that's where the right middle lobe is. So that's why it's most likely a right middle lobe. Good. So that's consolidation. What about here? Normal, abnormal, don't know. So we look at the airways and we look at the little bronchioles, right? So the heart is, it's a little prominent. I think it could potentially be projectional. Bronchioles, you start to see the bronchioles a little bit more, right? There's here, for example, in the retrocardiac, you see the bronchi, but here you really see the bronchi very well. It's outlined because it's thickened. The bronchial wall is markedly thickened on both sides, and you see this cuffing around the bronchiole. So this is what we see with bronchitis, which is just inflammation of the bronchi. And you get they call it cuffing. It's because of the thickening, the muscles that are thickened. And so it looks like it's cuffing it. And you normally should not be able to see that. So that's bronchitis, acute bronchitis, which is different from chronic bronchitis. We'll get to that. Pneumonia. So this is coming to you from first aid. So there's different types of pneumonia: lobar, bronchopneumonia, and interstitial pneumonia. And they're a little different. Lobar involves the entire lobe. Most frequently is strep pneumoniae. Bronchopneumonia is infiltrate into the alveoli, so it's sort of patchy, and we'll see some examples of that, and it can be multifocal. Interstitial, or they call it atypical pneumonia, involves not the alveoli, but the stroma around the alveoli. So the interstitium is involved in patients. They call this like walking pneumonia because it's a little bit more indolent. We see with mycoplasma, Legionella, things like that, and viral. We'll see some examples. Okay, so now we're going to get to a little bit more. So we're going to talk about organizing pneumonia. BOOP, I guess. It's been renamed now. It's called cryptogenic organizing pneumonia, COP. So these are infiltrates, as you see here, and they're usually peripheral in distribution. So this is how we typically see of cryptogenic organizing pneumonia. Cryptogenic because we don't know what causes this, but it could be a sequelae of a lot of conditions, drug toxicity, patients like with certain immune, like rheumatoid arthritis, for example. I mean, there's various different causes of cryptogenic organizing pneumonia, but they're usually peripheral, and then they can change in location. They don't respond to antibiotics. In contrast, here we see little like bronchocentric, so it's around the airways, these little infiltrates. And I mean, can't really say for sure it's aspiration, but typically aspirations, it involves the dependent portions. Like if they're sleeping and they're aspirating, it'll go down into the dependent portions of the lung posteriorly instead of anteriorly, for example, and in the lower lobes. And then you have, this is a little different right now. This one is a little bit more fuzzy. It's sort of diffusely hazy, and you have the central-lobular nodularity, ground glass. We call this ground glass appearance. It's like, those stained glasses that kind of just has this not clear but ground glass, or it's named after that, ground glass appearance. So this is typically what we see with hypersensitivity pneumonitis. The lungs are sensitive, or they become sensitized to something. And for example, patients with like birds, pet birds and whatnot, they, I think the feces like have something that irritates the lung, and so then it becomes incredibly like sensitized, and then they develop these hypersensitivity pneumonitis, HP. So pulmonary hypertension. Sorry, can you, Josu, I forget what the pulmonary hypertension was referring to. And then the second question was, does the entire lung become ground glass or only a lobe? The entire lung becomes ground glass, typically with hypersensitivity HP, because the antigen is being exposed to the entire lung. Okay. This one, in contrast, is bronchopneumonia. I mean, it's all infectious, so you're going to treat them the same way. But what happens here is the bronchi, you get infection, and it's going into the alveoli. It's like bronchopneumonia. It's still pneumonia. I mean, the patient needs probably antibiotics. But these findings show you what part of the airways are involved. So here, in contrast, the terminal units, the alveoli, you can see them really well here, quite pretty. This is bronchiolitis, so this is the most peripheral parts of the airways, and these are opacified with junk, pus, water, blood. So we call that bronchiolitis, and we call this tree and bud appearance. It's like this little tree and bud, because that's what it looks like here. And most common by far causes aspiration pneumonia. They aspirate stuff from the enteric contents, and then it goes into the airways and plug up the airways. And over time, they can get chronic airways disease and bronchiectasis, which means dilatation of the bronchi from chronic aspiration. Okay, but moving on to neoplasms. Patients, vocal cord, okay, so, going down the list of USMLE content list, so vocal cord polyps, nasal polyps, and juvenile papillomatosis. So here is the nasal, the nares, and then you have the, what do you see here? Normal looking head and neck CT, or not normal? It's deviated. I think it's not too bad. Maybe a little bit. Yeah, I think all of us have like a slight deviation, but not too bad. Looks like there's a little mass. Yeah. So there's a little soft tissue nodule here. So this is a nasal polyp. Good. And then what do we see here? Where are the soft tissue nodules here? With the stars, yeah. Yes. So there's you have these the arrows are pointing to these little soft tissue nodules here, and then The stars are pointing to the cavitation. So this is what happens in respiratory papillomatosis, which is due to HPV. They skip proliferation, and then when they make their way down into the lung, they then cause cavitation. And then what about here? So this is at the level of the larynx. This is the hyoid bone. What do you think here? Vocal cord. Adele had this. Laryngeal papilloma. Yeah, it's a vocal cord polyp. Okay. So more neoplasm. So head and neck cancer. So those are the benign stuff, and these are the malignant stuff. So the most common cause is squamous cell carcinoma, and usually from smoking, HPV, and EBV. So this is what normal looks like. You have the nasopharynx here, and then here you have this mass that's facing the nasopharynx. So Andrea, I had a question. So do they remove polyps with surgery? They can do laser, yeah. So they like go endoscopically and then just laser the little polyps out. So where was I? Yeah, so this is the MRI. So the nasopharynx here is nice and clean and open. And here, on the other hand, you see this mass that's essentially effacing the nasopharynx and almost obliterating the airways. So that is SCC, and it's field cancerization because if they smoke, you know, it's like the entire mucosa is exposed to it, not just one area. So the most common type of head and neck cancer is squamous, like everyone said. Okay, moving down to benign lung. So solitary pulmonary nodule, bronchial carcinoid tumor. These are benign lesions. There's a lot of causes of solitary pulmonary nodule. So here's an example of one. So, you know, here you have the intercostal muscles and there's fat, that's dark area. You have bone, and this one has contrast in the aorta. So the attenuation, you can look at the attenuation. So here there's mixed attenuation. Some parts of it are black, some are a little bit more gray. And that black part looks like the black part of the fat. So this is fat-containing lesion. And so there's usually only one type, and that's called hematoma. So that's benign lesion when you see fat attenuation. But SPNs can be from a lot of different, you can have infection, granulomas, round pneumonias, abscesses, amyloid, sequestration, bronchiogenic cyst. What do you see here on this slide? So this is a chest contrast enhanced CT because you see the aorta or pulmonary artery being lit up. And then this is the left main bronchus, the right main bronchus here. What do we see here? So the green arrow is pointing to a little lesion, an endobronchial lesion. This is a classical presentation of carcinoid. Andrea had a question. Did they do that to Adele? Oh, you know, I don't know exactly what she had done or how they removed her vocal cord polyp, but I'm sure they did it minimally invasively because she still sounds amazing. So let's go back to, so this is carcinoid. So carcinoid tumors are benign. They have outstanding prognosis, and metastasis is rare. Symptoms are typically due to mass effect because you get endobronchial obstruction, so you can get collapse of the lung. And sometimes patients can develop this carcinoid syndrome, flushing, diarrhea, wheezing, from a hormone that's produced. And what is that hormone called? We can see carcinoid in the GI tract as well. It's all part of a larger umbrella called neuroendocrine tumors. But yeah, some carcinoids, especially like ileal carcinoids and endobronchial carcinoid like we see, can release serotonin. And serotonin is what causes all of this problems, flushing, diarrhea, wheezing. And they're not associated with smoking like certain lung cancers are, like squamous cell carcinoma. And they have, it's a neuroendocrine tumor. That's the new classification. We don't really call them carcinoid anymore. They're just neuroendocrine tumor. And then we say low, moderate, or high grade. And carcinoids are in the low grade differentiated category, looking at Ki67 expression. So moving on to malignant cancers, tumors. So lung cancer is the leading cause of cancer death in the United States. 140 cancer deaths per year. This is the second leading cause of cancer death is in men prostate and in women breast cancer. And do you know what the proportion is compared to lung cancer death? Very small. So breast cancer kills 30,000 women. Prostate cancer kills 30,000 men. So about 70,000 together. So it's half of the death caused by lung cancer. Interestingly enough, we have the opioid epidemic. Do you know how many people die each year of opioid overdose? To give you a proportion and the magnitude of the significance. Any guesses? 100K? That's pretty good, yeah. So 70,000 people die every year from overdose. So it's a pretty significant crisis, right? It's same number of death as from breast and prostate cancer together equals the number of deaths from overdose. It's really sad. So let's go back to lung cancer presentation. So patients cough, hemoptysis, bronchial obstruction, chest X-ray. So now we know patients who are at high risk we can screen for lung cancer now. Lung cancer screening with low-dose CT. It's approved and now endorsed by USPFTF, U.S. Preventive Task Force, for patients who have 30 years, pack years smoking, and are at a certain age, and it reduces mortality by 20%. So it's the same amount that breast cancer screening reduces mortality from breast cancer, 20%. So for the first time, cancer deaths from lung cancer have gone down. But patients who have lung cancer, they can metastasize, typically to the adrenal glands, brain, bone, liver. So lung cancer is divided into small cell and then non-small cell, which is everything else: squamous, adenocarcinoid, and large cell. So what's the most common cancer? What's the most common type of lung cancer? Any guesses? It used to be squamous, but now it's adeno. Yeah. So with smoking, anti-smoking campaigns and whatnot, squamous SCC has gone down, and now adeno is the most common type of lung cancer, which is not related to smoking. Adenocarcinoma is actually the cause of the death of that neurosurgical resident at Stanford. I don't know if you guys heard about him, but he had metastatic adenocarcinoma and passed. He was about to finish residency. In the lung, metastases are usually much more common than primary lung cancer, but they're usually multiple. So lung cancers, metastases to the lungs are typically from breast, colon, really any tumors. So in the lung, metastases are more common than primary. This is true. Neoplasm. So these are the different types of neoplasms. We're going to talk about squamous cell first, and typically this is from smokers smoking. I guess similar to squamous cell of the nasopharynx and even squamous cell carcinoma of the esophagus. They're usually central hilar, perihilar masses. They can cavitate, and I guess this is something you need to know for first aid. They can produce PTH related protein and can cause hypercalcemia. Little notes for your first aid exam, I guess. Step one. Adeno, on the other hand, are usually peripheral, not central, and they're not related to smoking. And they have these tyrosine kinase mutations, KRAS, EGFR, ALK, which which is pretty amazing because now they have ALK inhibitors, EGFR inhibitors, ERISA, KRAS inhibitors. So now they can give targeted tyrosine kinase inhibitors. They call them targeted therapies, which can, I mean, patients, if they have a mutation and they get these targeted agents, I mean, their tumors go away, which is incredible. It's associated with hypertrophic osteoarthropathy, which causes clubbing. And you can have an in situ subtype called, it used to be bronchoalveolar carcinoma. Now it's called adenocarcinoma in situ, which is the pre-malignant version in situ because the basal membrane is intact and has not been disrupted. So patients typically have this hazy appearance, so adenocarcinomas as well as carcinoids have no or lesser association with smoking, in contrast to squamous cell carcinoma. Okay, and so this is all coming from first aid. In contrast, what do you see here on this chest radiograph? Normal, abnormal? If abnormal, which side? Oh, there's a question. Sorry, I missed the question. So what is the age of onset of adenocarcinoma? There is no preference. Like, it happens to young people, older people. There's not. That's like the one thing that, you just get unlucky. Yeah, it's really sad. Do you know what the leading cause of death in our cohort is? Like, professional physicians. Yes. Okay. So Peter, there's a mass. We're getting a little sidetracked, but yeah, no, cancer is a leading cause of death in our group, physicians, young physicians. He's one of many others who have passed. So yes, Peter, there's a left side, there's a mass in the upper lobe. Yeah, so there's a peripheral large mass. And it's a mass because you have this convex border. So this is a large cell. It's very aggressive, and patients have poor prognosis, less responsive to chemo. And this is your first aid knowledge, pleomorphic giant cells, and they can secrete beta HCG. What about here? What do we see here? Okay, so here we see this consolidation in the apex on the right side. So this is an apical lesion. Here the density is symmetric, so this is from the breast shadow. It's a woman. You can see the breast shadow here, so that's normal. So this is called a Pancoast tumor. Typically, if it's locally invasive, it's going to compress the structures surrounding it, the nerves, so they get, if it involves the superior cervical ganglion, they get Horner syndrome, ipsiladostosis, mitosis, meiosis, and hydrosis. I don't know if anyone has ever actually seen that. Anyways, if it compresses the SVC, which is here, then you can obstruct the venous return and then cause SVC syndrome, where you have ipsilateral, marked edema. Okay, so we're going to keep going. So now we're going to talk about, so we talked about squamous, adeno, giant cell, small cell. So we're going to talk about now pleural neoplasm. So this is a chest CT, and so we see on the left side there's abnormal thickening along the margins, which is where the pleura is. And we also see lymphadenopathy. So this is mesothelioma and is associated with asbestosis exposure. Patients get pleural thickening, and I guess you can see some MoMA bodies on histo. And then this is more first aid stuff for you to memorize: cytokeratin and calretinin. Smoking is not a risk factor. It's more of an occupational exposure from asbestosis. Okay. Secondary neoplasms, basically metastases, most commonly from breast, colon, prostate, and bladder. So you see here all these little tiny nodules everywhere in random distribution. This is your metastases. Okay, so we're moving on to lung disease. So there are two types, obstructive and restrictive. So obstructive are like bronchitis, emphysema, asthma, in contrast to restrictive, where like the actual lung is kind of like stuck. Obstructive, you have like in the bronchitis, like the airways stiffen. Emphysema, you get the alveolar destruction. Asthma, you get inflammatory airways disease, so then patients they have wheezing and stuff. Bronchiectasis is dilatation. Restrictive, like the parenchyma is bad. So ARDS, acute respiratory distress syndrome, and neonatal distress is very similar. It's just ARDS is in adults and neonatal respiratory distress is in children. And the pneumoconiosis, these are work-related exposure. You also get sarcoid, so the interstitium is bad. So it's restrictive. Okay. The flow volumes, this is coming to you from first aid. So the flow volumes, this is normal flow volumes. And in restrictive, where the interstitium is bad, it moves to the right. So the flow volumes decrease because the interstitium is bad. In contrast, obstructive, the flow volumes are big. So it's not that it's restrictive, it's just you have airways thickening or obstruction. Like destruction of the alveoli. So patients with obstructive, they have high flow volumes. Patients with restrictive interstitial disease, like problems, have low flow volumes. Obstructive airways disease, so asthma is one of them. These are the 4 types of obstructive airways disease that you should know about per first aid. Chronic bronchitis, emphysema, asthma, and bronchiectasis. The question is, left side, okay, no, we did that already. Can you explain the difference in flow volumes again? I will try, but I hope you ask your pulmonary lecturers because this is totally up their alley. My area is more the structural changes that we see on imaging. Okay, restrictive lungs are like the interstitium is bad. So presumably, if the interstitium is bad, let me see. Actually, I'm not going to try to explain it to you because I don't want to like tell you incorrectly. So from my standpoint, just know that this is what happens to flow volumes. And then I would then refer you to the pulmonologist. I'm not sure who's giving you lectures. Oh, I think you had like Dr. Fargo. Fargo gave you like flow volumes or PFTs, right? So he would be the one to ask actually. So I'm gonna pass that question to him if Uncle yeah. Yes. So obstructive airways disease. So obstructive airflow resulting in, okay, so this is coming to you from first aid. So in obstructive airways, so we said asthma, bronchiectasis, and emphysema, you get the airflow, like the flow of the air is like problematic. So airways close prematurely at high volumes. So for example, in asthma, the airway, you get thickening and inflammation, so it becomes really narrow. It's like if you're going down a tunnel, going down the subway tunnel or whatever, and now all of a sudden, like the tunnel becomes really, really narrow. You can imagine how flow through that tunnel will become markedly limited. So you still have flow. In fact, there's too much flow, like a lot of air, and it's not able to go through that tunnel fast enough because the tunnel has really narrowed. So their flow, I guess that's why they have really big volumes. It's just they're not able to transfer that volume appropriately because it's like the narrowing of a subway, for example, or a tunnel. So they get chronic hypoxic pulmonary vasoconstriction, which can lead to core pulmonary hypertension, which can lead to right heart failure, and those are the causes. So asthma, it's a you sensitize. It's an allergen. The muscles, the smooth muscles in the bronchioles, they get big hypertrophy. So the airway itself gets super narrowed, like that tunnel that gets really, really narrowed. And it can be triggered by various causes, viral, allergen, stress. So you need to, this is how you diagnose asthma. And then they get a cough, wheezing, whatnot, and they need to get And then you get peribronchial cuffing, so thickening of the airways on chest X-ray. So this is another type of airways obstruction, emphysema. This is due to the destruction of the alveoli. So they're not really elastic anymore. They lose their recoil. So then you're not able to properly transfer that airway. Even though there's a lot of air within the alveoli, it's not squeezing well. So then you're not able to like breathe out very well. So there are different types of emphysema. Central acinar, or central lobular, this is due to smoking, usually in the upper lobes, because the smoking carcinogens sort of travel up north because it's airborne. In contrast to pan-acinar, which is a genetic problem, alpha-1 antitrypsin, so the entire lung is affected and there's no upper lobe distribution. So patients, to try to get overcome the problem with elastic recoil, they purse their lips to keep the airways open and then prevent airway collapse during expiration. Okay, so this is an example of emphysema. You see there's like just destruction of the alveoli, and this is central lobular, upper lobe predominant, which we see with smoking. In contrast, this is panlobular, so like you get emphysema all throughout the upper, mid, and lower lung fields, and this is what we see with alpha-1 antitrypsin deficiency. So this is a normal lung, this normal parenchyma. In contrast, you see these big holes in the lungs from destruction of the lung parenchyma. So there's a lot of air there, but they just can't get that air out because the airways collapse. So they have to purse their lips so that it keeps this pressured within the airway so that it can go out. Normal lungs on the left, and then on the right you see really hyper expanded lungs, flattening of the diaphragms, and lucid lungs. So this is what we classically see with emphysema or COPD. In contrast, bronchitis, they call them blue bloaters. They have hyperplasia of the mucus secreting glands in the bronchi. So the little glandular cells are hypertrophied or hyperplastic. So you get thickened wall essentially, sort of like asthma, where you get thickening from inflammation. Chronic bronchitis, patients get cough for more than 3 months for over 2 consecutive years. That's the diagnostic criteria. And patients typically have wheezing, crackles. They're blue, so they're cyanotic due to shunting, late onset dyspnea, CO2 retention, and then they get polycythemia. Chronic complications, they can get pulmonary hypertension and cor pulmonale, which leads to right heart failure. So chronic bronchitis is due to gland hyperplasia in the bronchi. Okay, so more obstructive airways disease. So this is bronchiectasis. So these are the airways here, and it's dilated. You can see it dilated throughout the upper, mid, and lower lobes. And this is what we see with patients with cystic fibrosis. But it can be from other diseases as well. Chronic necrotizing. So bronchiectasis, what causes it is necrotizing infection of the bronchi that causes permanent damage, and then they get purulent sputum, recurrent infections, hemoptysis associated with obstruction, poor ciliary motility. So smokers get poor ciliary motilities. Cardiac angers, where you have a genetic defect. Patients with cystic fibrosis, and then they're at risk for ABPA, allergic bronchopulmonary aspergillosis. So then you get fungal balls, aspergillomas, within these ectatic bronchioles. So the difference between blue bloaters and pink puffers, so these are our emphysematous patients who sort of, they have to purse their lips to keep their airways open. And in contrast, the bronchitis people who have like thickened bronchi, and then they get cyanotic. So a 65-year-old man with a pinkish hue, thin barrel chest. This is an emphysematous patient. Pneumoconiosis. Okay, so it's 3:47, so I'm going to go a little faster. 64. Okay. Pneumoconiosis is work-related exposure lung disease. That's what pneumoconiosis is. And there are several types: coal worker, silicosis, and asbestosis. Different work have different kinds of exposures. But basically, they all, cause lung disease, and they increase chances of cor pulmonale, which is right heart failure from pulmonary hypertension, cancer risk, and Kaplan syndrome. This is coming to you from first aid. So that Kaplan syndrome is rheumatoid arthritis associated with pneumoconiosis and lung nodules. So here is a case. So patient has a diagnosis of pneumoconiosis. So you get this like subpleural interstitial lung disease here. And you get little nodules here and there. So well, it's sort of more apparent here, but a constellation of these findings suggests the syndrome of Kaplan. Why does it happen? I don't know. Just another little factoid for you to remember. A person has rheumatoid arthritis, pneumoconiosis, and intrapulmonary nodule. What's the syndrome? So that was Kaplan. Pneumoconiosis, so this one is asbestosis, and classically asbestosis, it's in the lung basis, and you get plaques, calcified plaques along the pleura. So these are like almost pathognomonic for asbestosis exposure. It's a type of interstitial lung disease, so the interstitium is bad, it's stiffened, and they are people who build ships, do roofing, plumbing. They get these calcified plaques that are pathognomonic, and there's increased risk of bronchogenic cancer and mesothelioma. Okay. Another work-related lung disease is called silicosis. People who, I guess, in the sandblasting business and mines, it's like a reaction to the silica, and then they get scarring, fibrosis. These usually involve the upper lobes. So first aid, there's an acronym or like a eponym, or yeah, there's a silica and coal are from the base, so but they affect the roof, upper lobe. In contrast, asbestosis is from the roof. It used to be put in insulation of the walls, but it affects the lower lobes, base. Okay. So asbestosis affects the lower lobes, and then the silicosis affects the upper lobes. Berylosis is due to exposure, work-related exposure to beryllium in the aerospace and manufacturing industries, and they get similar fibrosis scarring. Affects the upper lobes. Hypersensitivity pneumonitis, it's a type of restrictive lung disease, so the interstitium is bad, and they get this due to exposure to birds. So farmers can get this. This type of condition is due to mixed type 3, type 4 hypersensitivity reactions. They get chest tightness, cough, and headache, and it's often seen in farmers. So this is hypersensitivity pneumonitis. Okay. Pneumoconiosis. So we're going to talk about eosinophilia and Loeffler syndrome. Patients, they have half of the people have asthma, and so they get respiratory symptoms, and then blood eosinophilia. And Loeffler syndrome is a type of eosinophilia. Half of the patients, so I think most of you guys got this right. So patients with eosinophilic pneumonia have concurrent asthma. Loeffler syndrome, these patients have asthma, and they also have respiratory symptoms with blood or alveolar eosinophilia and pulmonary infiltrates. Interstitial and atypical pneumonia. Here we see opacity in the left lung field here, sort of diffusely, right? It's not a consolidation, sort of this hazy opacity. And these are interstitial, so it involves the interstitium. And we typically see that with Mycoplasma, Legionella, things like that. Okay, so then the last part of lung disease is UIP, interstitial lung disease, a little bit, I guess, not too much, but UIP it's called idiopathic because we don't know what causes it, but they classically get fibrosis and this honeycombing appearance here, like a honeycomb. So lung cysts that are sort of adjacent to each other. And that's from repeated lung injuries that causes this fibrotic restrictive lung appearance. Okay, so I'm going to just briefly touch on respiratory failure. As you can see, there's a long list of items, and trying to cut back because the lecture is sort of already long as it is. So we're going to just briefly touch on ARDS, but patients get respiratory failure. There's the alveoli are damaged, and so you get leakage into the alveolar space. And there's this Bartus syndrome that you should know per first aid. Sepsis, pancreatitis, pneumonia, aspiration, uremia, trauma, and amniotic embolism. I don't know when you're going to ever use this, but these are sort of like step one material. You sort of just have to know, and then you can forget it after. But ARDS, this is important for you to know clinically because we see this more commonly than not. You get endothelial damage, and so you get leakage into the alveolar space. And in children, it's called a hyaline membrane disease because the neonates, they're usually immature neonates, they don't produce surfactant, and so they get an equivalent called neonatal distress syndrome. And so those patients have to be carefully monitored, and they're usually ventilated because they're not able to, their lungs are compromised. Okay, so just touching on a couple more items that I think are more common than not, and you'll see one is PE. So a lot of people die from PE. We said 140 died from lung cancer, about up to 200 die from PE. So it's like a very significant disease. You can have different types of emboli: fat, air, clots, bacteria, and septic emboli, amniotic fluid, or tumor. Here's your FAT-BAT acronym. So patients with PE, basically, this is what we call VQ scan. They breathe in these radiotracers, and then we also inject it into the intravenous area. So if you have patients who have photopenic segmental defect, that suggests that there's blockage in the vessel to those area. So that's highly concerning for PE. But we usually use CT, PE protocol, CT pulmonary emboli protocol. It's a CT angiogram. But there are different types of PE you should be aware of. Fat emboli, this is commonly seen in patients who are post-orthopedic surgery or IF because they have a fractured bone and then the bone marrow sort of go into the blood, and that can cause emboli. Amniotic fluid embolism in postpartum patients. Air emboli, these are one of the diseases of caisson. We see that in divers who come back up to the surface too fast. The nitrogen bubbles precipitate into their blood and then can cause an air emboli. And these patients are treated with hyperbaric oxygen. So here's an example of a PE. So here's your main pulmonary artery, right and left. And then there's a clot there. Oh, let me see, maybe it's like a, where's my clot? Here's one clot here. Sort of have to go through, but here's a little filling defect here. There's a bigger one. Where's the bigger one? JPEG. Oh, here's, okay. So what else? So that's a CT-PE protocol. It's the angiogram. Okay. You look for filling defects. Okay. I'm going to go through the pleura, just touching on this. This is very limited coverage, but this is a giant abscess. And so you see the pleura here, and so you see this fluid collection with air bubbles. So that's called an empyema, and that's important because those have to be drained with the pigtail catheter. You can't, they won't respond to antibiotics because the antibiotics won't penetrate this process, so they have to be drained. More pleural disease. We're just touching on this. We're not going through every single pleural disease, because the lecture's already pretty long. So pneumothorax here we see, and here in the scout, the lung is collapsed, and then we see, lucency. So there's 4 different types of pneumothorax. Primary spontaneous, which is due to sort of these young, tall people who have like little blebs that pop. Secondary spontaneous, if you have emphysema, it is of patients with infections. Mechanical ventilations, they use high pressure, so it just pops. Trauma from rib fractures, penetrating injuries, stab wounds. Tension pneumothorax, we mentioned briefly before. This is when you have that ball and valve effect, so then you have just constant pressure into the pleural space, and you can have mass effect on the adjacent structures like the heart, which can cause respiratory cardiopulmonary compromise. And that's it. So we did very limited coverage of pleural disease, respiratory failure, and we didn't touch this because the lecture was already kind of long. Questions?